Very good morning, all. Thank you, KSOS, for this wonderful opportunity. Thank you, Dr. Anju. I'm going to talk about OCT angiography. So, why OCT angiography? OCT angiography is a nascent, fast, dye-free, non-invasive technique to visualize and assess retinal and choroidal vasculature abnormalities. It provides us with cross-sectional as well as en-face images to detect structural, perfusion, and vascular flow abnormalities. Unlike FFA and ICG that detects blood flow only in the complete retina because it treats the retina as a unit layer, you can detect blood flow with the help of OCT angio in superficial, intermediate, deep retinal capillary plexus as well as choriocapillaries. So there are certain diagrams in OCT. One is NFAS. So NFAS is nothing but 2D representation of the 3D volumetric data. And the depth of the retina where this NFAS is taken is known as segment. If the patient moves his eyes, you can have these motion artifacts as you see in this image. Then you have projection artifacts, flow, flow void, and various indices. Then there are other quantifiable variables in OCT angiography like foveal avascular zone. It is the size of the fovea, the avascular zone of the fovea. Acircularity index. It is how acircular your fovea is from a perfect circle. Vessel density. FD300 is vessel density around 300 micron region around foveal avascular zone. Perfusion density and extrafoveal avascular area is an avascular area outside the 1 mm diameter circle center over the fovea. So why do we need to know this? Because these quantifiable variables can act as a sensitive biomarkers. As FD300 can detect diabetic retinopathy before the clinical DR happens, extrafoveal avascular area in the superficial capillary plexus can discriminate non-diabetic retinopathy from an NPDRIs, while vessel density in deep capillary plexus can distinguish NPDR from the PDR. So in our study, in our pioneering study as well as study from Belly et al., we can clearly delineate between a neovascularization as well as collaterals by just looking at two things. One, the morphology of the vessels. Second, the flow. If you see flow in the vitreous with an abnormal vessels present, you're probably looking at a neovascularization. OCT angiography can not only detect choroidal neovascular membrane, it can tell you which is the type of the neovascular membrane it is. It is type 1, type 2, type 3. And if you see this abnormal vasculature in the superficial, intermediate, and deep capillary plexus with the flow, it is probably a type 3 or a McTel. Oh, sorry, type 3 or an RAP lesion. So manual segmentation is very important. Look at the image on the right. If you see an abnormal segmentation, make you feel that this is an CNVM, but then if you correct the segmentation, it is gone. Always correlate the NFAS image with the structural image. Look at the central circle. You think it's a CNP area, but it's not a CNP area. It is rather a cystic spaces that is visualized as a CNP area or a flow void area in OCT angio. So always correlate the NFAS with the structural OCT. OCT can also detect the flow void area in the middle or the deeper capillary plexus, allowing us to understand and visualize pathology which were affecting only some certain layer of retina, like paracentral acute middle maculopathy or sickle cell maculopathy, which affected middle or deeper layer of retina. With OCT angiography can also help you to identify NV in RVOs. You can also assess the assessment. You can also assess these patients how well they are doing on the treatment, because reduction in the size of this neovascular complex with decrease in the flow in the over there can help you understand that your treatment has taken a good effect. Not just that, OCT angiography works well in uveitis, because if you see these flow void areas, choroidal granuloma in VKH. So when these flow void areas are gone in the choriocapillaries plane, this means this is the time when you can stop immunosuppression or steroid in this patient. So it guides you the treatment. At the same time, in certain identities like multiple events on white dot syndrome, where you have choriocapillaritis, because choriocapillaries are so small, and the problem with the OCT angiography, it does not detect flow in the smaller vessel, can help you to differentiate the other white dot syndrome. So with the dream OCT coming up now and ultra wide field OCT, you can even tap into the diseases which was only limited to ultra wide field angiography, that is like IRWAN. So we literally see an IRWAN disease with OCT angiography. In this, I always quote this article by Brazilian et al. So SWEPSOS OCT, look at this OCT. This is an FFA and an OCT. FFA you don't see, you just see a blocked fluorescence. But you do an SWEPSOS OCT in this patient, you see that macroaneurysm. So now the hemorrhage with macroaneurysm, you know the region of macroaneurysm with the help of SWEPSOS OCT angiography. So that's not it, because with the help of OCT or NGO, you can detect CNV chronic CAC, you can identify MACTEL, it can help you to help as a pre-perimetric test in glaucoma, as well as in various hereditary and retinal disorders. So how and why? So always remember that you should know the anatomy, because until unless you know it, you cannot identify it. Second is always adjust the segmentation manually. Look for abnormal in the normal. Correlate the structural OCT with the and fast OCT. Look for the flow as well. Apply the right scanning protocol to clinch the diagnosis. For example, if you're looking at a foveal region like in AMD, use the 3 by 3 mm protocol. When you're looking at an outer retinal disease or a disease which affects the periphery, use a wider frame. Scanning part is easy, interpretation is at its infancy. Just practice, practice to learn. Thank you.
Thank you for that enlightening and insightful talk, sir. We'll have the discussion at the end of the session, sir. Next is after Octa, we are moving on to OCT. So I'll be talking on mastering the art of retinal interpretation. So, how do we decode an OCT? What a general ophthalmologist should know. So, starting from the introduction, so as we all know, OCT is a non-invasive, non-contact transpupillary imaging system which provides high-resolution cross-sectional images. The principle is low coherence interferometry. So, next is moving on to the scanning systems and protocols. So scanning system includes time domain, spectral domain, and frequency domain. Time domain is broadband light source. That is, we can't picture the 3D images. Other than that, it is an older one. Nowadays, we are not using it. Next is frequency domain. It is CCD based spectrometer, and there is no need of any mechanical variation in time. Next is SWEP source, that is single photodetector is used, no moving mirrors, no CCDs. The spectralis OCT is the most commonly used one. It incorporates two imaging techniques, that is confocal scanning laser ophthalmoscopy for octa and autofluorescence. Next is OCT confocal images creates a transversal image of the retina corresponding the unforced place of the OCT. So next is after the systems, we'll move on to the OCT protocols. It includes 6 protocols. First is macular thickness, which is the most important one, because it is the most commonly and the most important one, because it has this line scan, which is the one we use for the thickness profile and commonly used one. Next is the ETDRS chart, which is used for the diabetic macular edema grading in ETDRS grading chart, which measures the thickness from the inner limiting membrane to RPE, and it consists of 3 circles: outer, inner, and the innermost circle. This is the 3 circles we see in the when we get an OCT. Next is the cross hairline image, which is white and black color coded image, which represents the images of the macula taken in the horizontal direction from temporal to the nasal area. Next is a raster scan, which is a selective scanning profile, usually taken at the angle of 30 degrees. So we have learned what are the protocols, what are the types of scans available, and what is an OCT. Now we get an OCT in hand. So when seeing the OCT, we should know which eye this OCT belongs to without even seeing the OD and OS. So while we see, this is a scan of a right eye. How do we know that? There is a thick RNFL hyperreflective band exiting from the ONH. That is how we identify which eye this OCT belongs to. So next is we know the protocols and which eye this OCT belongs to. Next is how do we analyze it? So we need to know the nomenclature of OCT. What words do we use to tell that? So first is band, that is a 3D structure which is defined anatomically. Next is zone. When there is no when the anatomical correlation is not clearly delineated, it is called as a zone. Next is RP Brux complex. So one of the layers described as zone as they are inseparable owing to the interdigitations. So next is we have learnt about the nomenclature. Now we will see what are the layers, what is the normal layers. My team will be discussing on the abnormalities in that. First is a pre-retina, vitreous anterior to the retina, seen as a non-reflective dark spot in the OCT. Faint dots can be seen, which are noise formed due to the electronic aberrations. Next is a vitreoretinal interface, well defined due to contrast between the non-reflective vitreous and the backscattering of the retina. The condensed vitreous overlying is called as the posterior vitreous phase. Next is epiretina. Is the anterior surface of retina. Epiretinal membrane is a common thing seen here. Next is the retina. Retina is again divided from anterior boundary is from the hyperreflective band of the ILM to the RPE. So these are the layers which can be seen in this retinal thing. And the outer, that is it can be also divided into outer retina, which includes this ISOS junction, RP, Brux, all this we have to look into each and every layer so that we don't miss anything. Next is the choroid, which can be easily seen with an EDI scan. So what we see, always see a depression in the middle of the scan. So what is that? It is an foveal cut. It is an area where the outer plexiform and the RNFL meet. So we have learned what is the normal things we have to look into. So what are we know the structures. So what are we going to look into it? It consists of qualitative analysis and quantitative analysis. First we'll go into qualitative analysis. It has two things. One is morphological studies and the reflectivity studies. So morphological studies, we have to see the overall retinal changes with the major areas which I have mentioned before. And next is the reflectivity thing. That is how we interpret an OCT. Hyperreflectivity and hyporeflectivity. Hyperreflectivity is what we see in white in color. Hypo is black in color. Next is shadowing. So these are the normal reflectivity of the structures, which is normal. That is RNFL will be seen as white. And these you can take a photo if you want. And I'm not going into reading all that in detail. These are the abnormal pathological reflectivity. I am not going into detail because my team will be discussing each and everything in detail. These are the abnormal high reflectivities and medium and low reflectivities. So next we will be moving on to the quantitative analysis, that is retinal thickness. Based on the retinal thickness only, because for the CSME, diabetic macular edema, based on the retinal thickness only we will be deciding on the treatment. So in retinal thickness, mainly 3D cube scan and the radial scan generates an early treatment for diabetic retinopathy study, grid with thickness values displayed in the each sector. So these are the commonly used landmarks in measurements on OCT. CSME, center point retinal thickness. So next is the retinal maps. So these are the color maps which helps us to identify where the thickness is, and it is easier to explain it to the patient. So we know what to look into the OCT. So what to look for after this presentation, we have to know. Determine the scan quality first, then the overall scan profile, and evaluate the foveal profile, identify the foveal cut, carry out the structural assessment like observation of the layers, identify each and every structure. And these are the terminologies we will be using: this irregularities, thickening, elevation, interruption, fragmentations, rupture. And the advantage is non-invasive, non-contact, more repeatability, and limitations include, main limitation is media opacities and artifacts. So artifacts include this mirror artifact, vignetting, misalignment, out of the range, blink artifact, and motion artifact. Thank you. Next, we are moving on to the next talk, unveiling the vitreoretinal interface, OCT at work. Over to Dr. Minnie David.
Good morning. I will be talking on unveiling the vitreoretinal interface, OCT at work. Posterior vitreous detachment is the common phenomenon seen with the aging of eye. It can be complicated by persistent symptomatic vitreomacular adhesion and vitreomacular traction. VMT associated with epiretinal membrane and idiopathic macular holes. Patients may present with metamorphopsia, photopsia, and decreased visual acuity. OCT is helpful in visualization of macular anatomy, quantification of macular hole characteristics, and this facilitates the treatment decision making. Mainly 6 types of vitreomacular interface diseases. Depends on vitreomacular interface relationship. Can be vitreomacular adhesion and vitreomacular traction. VMA is the perifoveal vitreous detachment from the retina but remaining attached within the fovea without retinal abnormalities. And VMT is the retinal abnormalities due to traction from the adhered vitreous within the fovea. And depends on epiretinal proliferation. It can be ERM and LHEP, epiretinal membrane and lamellar hole associated epiretinal proliferation. ERM is the hyperreflective tissue along the retinal surface, and LHEP is the thick and homogeneous layer of material with medium reflectivity, usually accompanied by retinal defects. Next is macular hole. It can be lamellar hole or full thickness macular hole. Lamellar hole is a partial thickness defect in the retinal layers, and full thickness hole is a full thickness defect at the fovea. Then each one in detail. Vitreomacular traction. Normal age-related PVD may be complicated by persistent VMA between the vitreous cortex and the macular area following syneresis. Simple VMA not associated with the structural distortion of the macular architecture, and VMA may exert tractional forces on the macula, causing VMT increase during the ocular saccades during retinal distortion and disruption. Coming to grading of VMT, International Vitreomacular Traction Study Group classification. It can be VMA, VMT, and full thickness macular hole. Vitreomacular adhesion depends on size. It can be focal or broad, isolated or concurrent. And VMT also, it can be focal or broad and isolated or concurrent. And full thickness macular hole can be, depends on the size. It can be small, medium, large, and with or without VMT, and it can be primary or secondary. It's a case of VMT with stable vision. It's an 88-year-old female. Both are status post cataract surgery. Patient had a slight disturbance in vision, and patient presented with 6 vision. And OCT showing a VMT. It was a focal VMT, and patient's vision was stable. We advised regular follow-up in 6 months. It's a case of 60-year-old female with best correct visual acuity of 660 and 24. Patient presented with VMT with a macular hole. Patient underwent right eye vitrectomy with ILM peeling and C3F8 injection. Advised post-op positioning. Following post-operatively at 6 weeks, anatomical closure of hole with a 618 and 10 vision was improved. Next is epiretinal membrane. The proliferation of cellular tissue on the surface of the retina along with the inner limiting membrane appears as a grayish semi-translucent avascular membrane over the ILM on the surface of the retina. It progressively affects the central vision and causes metamorphopsia. OCT is the diagnostic procedure of choice for diagnosing and assessing the extent of epiretinal membrane and its impact on retinal morphology. Coming to stages of ERM, stage 1 is foveal pit is present with well-defined retinal layers. And stage 2 is absence of foveal pit with well-defined retinal layers. And stage 3 is absence of foveal pit with well-defined retinal layers and presence of an ectopic inner foveal layer. Ectopic inner foveal layer is the continuous hyporeflective or hyperreflective band extending from the inner nuclear layer and inner plexiform layer across the foveal region. In this image, the black star indicates the Eiffel layer. And this is a case of ERM stage 4 with a less vision. 64-year-old male with a 624 N12 vision and presented with left eye ERM with the FEP. And patient underwent vitrectomy with membrane peeling and SF6 injection following post-operatively at 8 week. Anatomically restored layers with a visual acuity improvement of 612 N10. Next is lamellar hole associated epiretinal proliferation. It's a thick homogeneous material of medium reflectivity on the epiretinal surface at the margin of lamellar defects, contiguous with middle retinal layers and conforms the retinal layers structures without exerting tractional effects. Originates from the proliferation of Muller cells. can occur independently or concurrently with tractional ERM in lamellar holes. Lamellar holes with LHEP are more likely to have larger tissue defects, disruption of ellipsoid zone, and poorer mean visual acuity. Next is macular hole. It's a full thickness defect in the neurosensory retina at the fovea. Most cases causes idiopathic and can be affects 6 to 8 decade of their life. Coming to the stages. So GIAS classification. Stage 1 is impending hole with 100 to 200 microns with foveolar detachment. Stage 1B is occult hole, 200 to 300 microns with foveolar detachment, clinically seen as a yellow ring. And stage 2 is small full thickness macular hole, less than 400 microns. Stage 3 is full thickness macular hole, more than 400 microns with or without an operculum. Stage 4 is full thickness macular hole with a complete PVD. So International Vitreomacular Traction Study Group classification, it can be small, medium or large. Small hole is dimension less than 250 microns and associated with 100% closure rate following vitrectomy. And medium hole is 250 to 400 microns with a 95% closure rate following vitrectomy. And larger holes are more than 400 microns dimension with 90 to 95% of closure rate following vitrectomy. Something about the macular hole indices. It's macular hole height, basal diameter, minimal linear diameter, macular hole inner opening. And tractional hole index and macular hole index are the main things we are looking. Tractional hole index is macular hole height divided by the minimum linear diameter, and the macular hole index is macular hole height divided by the basal diameter. Greater MHI and THI are associated with better postoperative functional outcomes, and MHI predicts the external limiting membrane restoration, while minimal linear diameter and basal diameter are predictive of anatomical closure. So, case of macular hole, stage 3, patient presented with the BCV of 636 and 18 vision, right eye full thickness macular hole. Patient underwent vitrectomy with ILM peeling and C3F8 injection. Advised strict post-op prone positioning. At 6 weeks, patient had anatomical closure of hole with an improvement of vision of 6, 18 and 12. Next is about lamellar hole. It's a partial thickness defect at the fovea, separation between outer and inner retinal layers with irregular foveal profile and persistent foveal photoreceptor layer. The involvement of photoreceptors at the ellipsoid zone leads to worse visual acuity compared to those with an intact photoreceptor layer. Most patients with lamellar macular hole remain stable over years, and mainly two types of lamellar holes are the degenerative and tractional type. It can be assessed by OCT. Degenerative type is displays a schisis-like configuration, LHEP, often ellipsoid layer disruption, slow chronic degenerative process causing loss of retinal tissue and the disruption of ellipsoid layer. It has the appearance of moustache. The sign is known as moustache sign. And tractional lamellar hole presents with a conventional ERM with an intact ellipsoid layer, and the appearance of top hat, it's known as top hat sign. These are the topics I'm discussing, and thank you.
Thank you, Minnie, for this insightful talk. Next, we all move on to the Seeing Beyond OCT in Retinal Diseases. Over to Dr. Juliana.
Good morning. Looking beyond OCT biomarkers in retinal disorders. So I'll be discussing the OCT biomarkers in diabetic macular edema, macular telangiectasia type 2 and drug-induced maculopathies. So what is a biomarker? The National Institute of Health defines a biomarker as a quantifiable biological parameter that is measured and evaluated as an indicator of biological, pathogenic or pharmacological response to a therapeutic intervention. So OCT biomarkers in diabetic macular edema. So when we deal with a patient with diabetic macular edema, we tend to see the OCT, see the thickness map and decide the treatment protocols. So here we are going to see about the OCT in detail and look for some biomarkers which can help us to predict the visual prognosis following our treatment. So the role of OCT was first established in the prospective study with Lucentis for neovascular AMD to monitor intraretinal and subretinal fluid for treatment decisions. Later, various studies have used PRN approach based on OCT in the treatment of diabetic macular edema. First biomarker is drill or disorganization of retinal inner layers. It is the inability to distinguish between the ganglion cell layer and inner plexiform layer complex and inner nuclear layer and outer plexiform layer complex. It is measured at the central 1 millimeter retinal zone. It is drill is defined as the area, the inability to distinguish at an area of more than 50% or more than 500 microns, which is considered significant, and it is associated with poor visual prognosis in eyes with edema or resolved edema. Greater drill at baseline is correlated with worse visual prognosis. An increase in drill during the 4 months period predicted a decline of visual acuity by 1 line. Drill is also associated with increasing severity of diabetic retinopathy, especially proliferative diabetic retinopathy. Diabetic patients with drill have reduced retinal function compared with those without drill due to defective retinal lamination. Next biomarker is a hyperreflective retinal foci. It appears as intraretinal hyperreflective dots, represents subclinical lipoproteins that extravasate after breakdown of blood retinal barrier. It measures less than 30 microns. It is characterized by the absence of back shadowing and its reflectivity is similar to RNFL. It is an important imaging marker for inflammation. HRF present inside the retinal cyst or lining the cyst borders is termed as pearl necklace sign. Such a sign is seen in advanced DME, and patients with such a sign may be refractive to treatments. Greater number of HRF is present in patients with higher HbA1c levels, which reflects a more ischemic retinal environment. And such patients respond better with corticosteroid implants. So, among the anti-VEGF, faricimab performs better with patients with hyperreflective foci. So, with reference to follow-up, patients with higher number of hyperreflective foci are associated with early recurrence of diabetic macular edema, and they require frequent follow-up. Next biomarker is the intraretinal cystoid spaces. Elevated VEGF levels affect the inner blood retinal barrier, leading to increased vascular permeability, resulting in extracellular fluid accumulation and cyst formation. They cause photoreceptor damage and affect the visual outcomes. Prognostic significance depends on the size, location, content, and its association with hyperreflective foci. Based on the size, cysts were classified as small, large, and giant cysts. Larger cysts are associated with macular ischemia and predict poor visual prognosis. Next, we see about the content. Hyperreflective signals within the cyst are associated with severe disruption of the blood retinal barrier. Fibrin and other inflammatory byproducts may fill these spaces, and they respond poorly with anti-VEGF agents. Location of the cyst about the center and cyst with associated photoreceptor damage are associated with poor visual outcomes. Next biomarker is the presence of bridging retinal processes. They are usually seen between the cystic cavities. They are associated with improved visual acuity with treatment. They represent residual neural elements comprising of Muller cells and bipolar cells. Their absence of bridging retinal processes signifies poor prognosis post-treatment, and visual acuity is unlikely to improve despite resolution of cyst. Those patients usually end up in foveal atrophy and thinning. Next biomarker is the macular thickness. So increased macular thickness is due to intra and subretinal edema. Central subfield thickness is defined as the thickness of the central circle of 1 millimeter diameter in the circular ETDRS grid map. When the retinal thickness increases beyond the stretching capability of retina, it can lead to damage to bipolar axons, leading to suboptimal visual gain. It is important to consider that CST alone is not a good and reliable biomarker to indicate the visual prognosis. We have to always look for the other associated biomarkers. Next biomarker is a subfoveal choroidal thickness. Greater baseline choroidal thickness predicted better response to anti-VEGF. It is presumed to have, patients with increased thickness have intact choriocapillaries, so lesser ischemia, so which explains the superior visual outcomes. Next biomarker is a subfoveal neurosensory detachment. Presence of baseline SRF was associated with better visual gains, and these patients respond better with corticosteroid implants. The very important indicator and biomarker is the integrity of ellipsoid zone and ELM. It is the most important biomarker. It is a direct indicator of photoreceptors and RPE health. Intact EZ have a better visual prognosis post-treatment. Long-standing DMEs leads to focal and diffuse loss of EZ showing suboptimal visual gain. Next is the vitreoretinal interface disorders. So they may be of two types, like anomalous PVD or the presence of taut posterior hyaloid membrane. They exert a tractional force and cause mechanical distortion, which is responsible for recalcitrant macular edema. Such patients benefit with surgical management like pars plana vitrectomy and removal of the taut hyaloid. So this is a summary of the OCT biomarkers. So negative biomarkers are presence of hyperreflective foci and larger turbid and central intraretinal cystoid spaces. The presence of bridging retinal processes is a positive biomarker. Macular thickness, it's important to remember that it is not a good biomarker. We have to always look for the other associated markers. And for very important and biomarker is seeing for the EZ integrity. Next is the OCT in MACTIL. Macular telangiectasia was initially described by Gas and Okayawa. It is a disorder in which there is abnormality of the foveal or perifoveal capillaries associated with loss of outer nuclear layers and ellipsoid zone. There are three types, 1, 2 and 3. I will be discussing about the biomarkers in MACTIL type 2. This is a classification proposed by Gas and Blody. This is the OCT based classification. So earliest OCT finding is the enlargement of the foveal pit due to the thinning of retina temporal to fovea. It occurs due to the thinning of ONL and Henle fiber layer temporal to fovea. Hyporeflective cavities may appear located in both inner and outer neurosensory retina. So ILM drape sign occurs when a thin membrane overhangs a central cystoid lesion at the fovea. Disruption of the EZ zone and the ELM may occur. So loss of Muller cells in the perifoveal region may contribute to increased hyperreflectivity of middle retinal layers. It is the most frequent early OCT finding seen in the fellow eye of a MACTIL patient. Superficial intraretinal crystals may be present in all stages of the disease. And the very important biomarker is the presence of retinal pigment clumps, which may be an early indicator of biomarker to predict the onset of proliferative stage of the disease. So outward bending and dipping of inner retinal layers to the outer retina due to the collapsing of the inner retinal skeleton. Proliferative stage is a appearance of hyperreflective lesion in the subretinal space, and it can also extend to the underlying choroid. So poor predictors of visual acuity are foveal contour irregularity, outer turning of inner retinal layers, hyperreflective RPC and EZ loss. So summary, drug-induced maculopathies. So biomarkers, preclinical HCQ retinopathy, the biomarkers are parafoveal thinning, inner segment ellipsoid attenuation, flying saucer sign, moth-eaten appearance of the ISOS junction. So implementation of advanced retinal imaging tools has resulted in the development of strategies to decrease the likelihood of toxicity. Utilization of OCT biomarkers plays a crucial role in early detection of toxicity. Thank you.
Thank you, Juliana, for this such a detailed, informative session. Till now, we have seen till retinal diseases in OCT. Now, we are going beneath OCT insights into subretinal pathologies. Over to Dr. Parvati.
Okay, good morning. Beneath the surface, OCT insight and choroid pathologies. Here I will be discussing the common diseases like dry and wet AMD, PCV, and CSCR, the OCT features. As we know, OCT plays an important role in identifying pathophysiology of common chorioretinal conditions and provides high resolution cross-sectional image of the choroid. And advanced techniques like EDI OCT, SSOCT has helped in better visualization of choroidal vasculatures, sclerochoroidal junction, and better idea into the disease pathologies. So coming to dry ARMD. Dry ARMD is characterized by presence of drusen, which are focal white yellow excrescence, and usually these are large drusen more than 125 microns, and in OCT we will get discrete elevation of the RPE, and here in second image we can see the bumpy RPE which is caused due to the drusen, and these are hyperreflective. And another entity is pseudodrusen or reticular drusen, which is highly correlated with development of end-stage subtypes of dry AMD, and usually these are seen in the sub-RPE space, that is above subretinal space above the RPE. So drusen we will get in sub-RPE, and reticular drusen will be seen in the subretinal space. Next is coalescence of this drusen can result in drusenoid PED, which is the elevation of RPE with a dome-shaped configuration, and usually this will be more than 350 micron in size. Here we can see the acute elevation of RPE with hyperreflectivity beneath, and this is drusenoid PED. And coming to the advanced stages of dry AMD, we have IRORA, that is incomplete retinal pigment epithelium and outer retinal atrophy. It is characterized by subsidence of inner nuclear and outer plexiform layer, that is the arrows, and signal hypertransmission into the choroid due to the loss of RPE and the layers. And if the area of this disruption is more than 250 micron, it is called CRORA or complete retinal pigment epithelium and outer retinal atrophy. And finally, we have geographic atrophy, which is the late manifestation of dry AMD, in which we can see localized sharply demarcated atrophy of outer retinal tissue and choriocapillaries, and in OCT we can see absence of the outer retinal layers between the yellow arrows, and absence of RPE, and due to the absence of RPE and thin choroid, hypertransmission can be seen just beneath this layer. Next is neovascular AMD. Neovascular AMD, the growth of abnormal vessels in the macular region and leads to structural changes in retina, and new vessels arise from the choroid and penetrate the Bruch's membrane, can result in fibrovascular tissue beneath or above the RPE, and this new vessel can also arise from retinal circulation. And this CNVM can be seen as hyperreflectivity, and if it is beneath the RPE, that is below the RPE, it is called type 1 CNVM, and if it is above the RPE, as in second image, it is called type 2 CNVM. In here hyperreflectivity is seen in the neurosensory retina, and sometimes we can get a mixed type in which both type 1, that is above and below RPE, can be seen, and there is a type 3 neovascularization in which the neovascularization arises from the retinal capillaries and goes into the choroid, and it is characterized by presence of serous PED with cystoid edema overlying the PED and intraretinal hyperreflectivity complex and subretinal fluid. Next is another sign of activity in CNVM, that is intraretinal and subretinal fluid. Intraretinal fluid can range from mild retinal thickening to cystoid spaces, large cystoid spaces, and subretinal fluid we can see as optically clear area between the RPE and neurosensory retina. On the both sides of this PED we can see subretinal fluid, those arrows, white arrows. Then pigment epithelial detachment, that is the separation of RPE from Bruch's membrane due to presence of fluid, blood or fibrovascular tissue. If the separation is due to fluid, serous fluid, it is called serous PED and is characterized by sharply demarcated dome-shaped elevation of RPE, and beneath it there will be homogeneous hyperreflective space and Bruch's membrane, underlying Bruch's membrane can be made out. Then we have fibrovascular PED, which is characterized by irregular elevation of the RPE. Here the RPE is elevated irregularly and there will be heterogeneous content, that is both hypo and hyperreflective contents are seen. in fibrovascular PED. And third type of PED is hemorrhagic PED, in which CNVM membrane bleeds into sub-RPE space or due to RPE tear. And this is also acute elevation of the RPE. There is a dome-shaped elevation of RPE with hyper-reflective material can be seen beneath the RPE layer, and due to the backshadowing, underlying Brooks membrane cannot be visualized. Next is the end stage, that is deciform scar, in which the retinal tissue is replaced by scar tissue. We can see hyper-reflective material there, and there is marked disruption of the retinal architecture, and another thing is outer retinal tubulation. These are seen in the circle, that is hyper-reflective structure surrounded by hyper-reflective band, and this has to be distinguished from the cystoid space, which is cystoid space is a sign of activity, and this is a sign of chronicity and no need for treatment. Then another entity is central posterior vitreous fibrosis, which we can see in late stages, where there is an unusually adherent posterior hyaloid which thickens at the fovea, resulting in the filling in of foveolar depression. Next is PCV. It is considered to be a variant of type 1 CNVM and is a part of pachychoroid spectrum of disease characterized by presence of serous polyps, presence of dilated polyps, severe exudation, serosanguinous maculopathy, and hemorrhagic PEDs. And there are some OCT features which are distinctive for PCV, and it include large PEDs, thumb-shaped PEDs, then we have sharp peak PEDs and notch PEDs, and here in the notch, near the notch, we can see a hyporeflective lumen, that is in the red arrow, which is surrounded by a hyperreflective ring, which usually correspond to polyps. Then other signs of activity like hyperreflective material, intraretinal fluid, subretinal fluid can be seen. And we have double layer sign, in which there is shallow detachment of RPE distinct from Brooks membrane, and there is hyperreflectivity in between the layers. It represents the presence of abnormal vascular network. Next, we have CSCR, which is the serous detachment of neurosensory retina, and is characterized by presence of optically clear fluid-filled cavity, and it is considered to be a part of pachychoroid spectrum, in which the choroid vessels are dilated in both affected and fellow eye, and this enlarged vessels can compress the choriocapillaries, and ischemia of outer retinal layers occurs, and resulting in diffuse pigment epitheliopathy, which can later lead to CSCR. And it is also in CSCR we can see serous PEDs in almost all eyes, and size of the PEDs can be larger, and in late cases we can see flat irregular PEDs which are shallow, hyperreflective, broad elevation of RPE. Then we can see focal RPE rip, which corresponds to area of leak in FFA, and double layer sign just like PCV can be seen, but here we can get uniform hyperreflectivity. And coming to the signs of chronic disease, we have hyperreflective dots. In the first image, we can see hyperreflective dots overhang the roof of SMD, and this represent the photoreceptor outer segment. Then cystoid changes, fibrinous materials, and flat irregular PED, which corresponds to double layer sign, which is a indicator for risk of neovascularization, can also be seen. Thank you.
Thank you, Parvati, for this insightful talk. Next, we are moving future forward, new frontiers in OCT technology by Dr. Shruti. Over to you, Dr. Shruti.
Good morning to all. Thank you, Anshu and KSOS, for giving me an opportunity to present my topic here. So we already learned about OCT in detail. So I am going to talk what next, what are the available advancements in OCT. So the first one is Octa. So, sir already discussed the Octa in detail, so I am not going to go in detail about it. So, basically, we retina specialist after OCT, we want to know the retinal vasculature, what are the abnormalities in the retinal vasculature, and nowadays, rather than ordering an FFA, we would like to do a non-invasive procedures like Octa. So. This is a common investigation we usually do in our OPD. So, sir already discussed about the Octa in detail. different machines available, and why we order Okta why we do Okta more rather than FFA. Like it has a shorter acquisition time. It's a non-invasive procedure, and it has it will provide both quantitative as well as the qualitative analysis. So the clinical application include the diabetic retinopathy and with age-related macular degeneration, retinal vein occlusion, and MACTEL. So it basically will help to analyze the non-perfusion areas, the neovascular bundle, and the foveal avascular zone can be quantified. So we will get an idea about how to proceed with the management. So when we order of Okta, we have to look for the artifacts like media opacity can decrease image quality, the projection artifact can we will get an overlap of the neovascularized superficial and the deep vessels, and the segmentation error in cases like macular edema. When IRF and SRF are present, we will not be getting a proper segmentation of the layers, and motion artifact due to eye tracking, due to eye movement. So the recent machine have eye tracking like system, so this motion artifact are less. So coming to the recent advances in currently available technology, what we have now is we have wide field and ultra wide field OCT. Wide field OCT, when we get a FOV of around 40 to 55 degree, and ultra wide field is FOV around 200 degrees. So the presently commercially available wide field OCT machines are the NIDAC machine, which can get up to 160 degree, 163 degree of ultra wide field imaging. Then Heidelberg machine, which is an SD-OCT, which can generate up to 55 degrees. And when this is combined with Storangi lenses, it can get up to 150 degrees. Then the Optos machine, which is an SSOCT machine, which can get up to 200 degrees of field within less than a 0.5 second. So this is an wide field OCT image. So yeah, this basically help to assess the peripheral retinal changes. Like in retinal vein occlusion in the left-sided picture, you can see the retinal thinning temporal to the fovea, and similarly the Okta image also showing the non-perfusion areas in the Okta image. So in the right hand picture, you can see in the peripheral retina there is a hole in the retina with an operculated hole. You can appreciate in the peripheral retina. So wide field OCT, what are the uses? It is basically used in peripheral retina changes, like to look for the ischemic areas in DR and vein occlusion, and look for the site of retinal breaks, peripheral retina detachment, retinal schisis, and also to in evaluating the choroidal lesions like melanoma, navis, hemangioma, and choroidal metastasis. So the certain challenges are there when we increase the field, that is optical aberrations, which can cause us increased noise to signal ratio. Then we have a pupillary and ciliary shadowing like artifact, due to which further reduce the image quality, and increased peripheral retinal curvature, and there is an inter-individual variation between the patients. So and we have, when we have to get a wide field OCT, we have to have a very high A scan rate to obtain this dense wide field OCT. So coming to the next is intraoperative OCT, that is IOCT. Intraoperative OCT allows for surgeon to utilize a microscope integrated OCT imaging in real time for feedback and image guidance in the operating room. Two major studies are undergoing, like Pioneer study and the Discover study, to investigate the utility of IOCT in various ophthalmic surgeries. So basically it is of handheld type is available, and microscope mounted and microscope integrated. This microscope integrated design help to visualize the real-time vitreoretinal interface interaction with the surgeon's instruments, and corresponding changes can be assessed intraoperatively. So this is an example of microscope mounted one, where in the circle you can see the IOCT is mounted with the microscope. So in this case, this is a macular hole surgery, where the surgeon already peeled the ILM, and you can appreciate the ILM flap over the macular hole. The same can be appreciated here. The ILM flap can be appreciated in IOCT in a closing macular hole. So, surgeon can assess intraoperative macular hole closure or identify the remnants of epiretinal membrane during membrane peel. IOCT may also be at the new need to use dye staining during macular surgeries. IOCT may also facilitate the therapeutic delivery of drugs like TPA or the placement of electrodes array for subretinal implants. So, coming to the emerging advancements for clinical use. So visible light OCT, that is now we already learned OCT use a near infrared light. So rather than using near infrared light, here visible light is used to capture the images. When we use visible light, we know the visible light spectrum, that is between the 535 to 700 nanometer wavelength is used. So this is a shorter illumination wavelength. So it will increase the axial resolution, that we will get a less than 2 microns of with smaller bandwidth. So this is an example of visible light OCT. In the left hand picture you can see the visible light OCT, and this is the near infrared OCT. So when we compare the outer retinal zone, here you can appreciate the different layers of outer retinal zone clearly with the visible OCT. When compared to the near infrared, it's already a blurred image type of picture we are getting. So this has got very and this is a useful technique actually, but currently it is used to measure the information such as oxygen saturation in retinal blood vessels and also the distribution of light sensitive pigment, that is spectroscopy. But the limitation are it has got a depth dependent dispersion of the light, thus decreasing the image quality, and also challenges in developing a broad band visible light sources and a relative intensity noise associated with it. So coming to the next emerging advance is the polarization sensitive OCT, that is PSOCT. PSOCT functions by analyzing the polarization state of the backscattered light and measuring its birefringence. So different tissue has different polarization state. So the fibrotic tissue containing collagen is particularly birefringent and thus imaged well by PSOCT. So Schuss et al. Demonstrated that PSOCT is useful for the evaluation of RP changes in the choroidal neovascularization in eyes with neovascular AMD, and the retinal fibrosis growth in the setting of the neovascular AMD can be tracked with PSOCT and segmented algorithms. So this is a picture showing PSOCT. You can hear the normal OCT picture. This is the area of RP atrophy, and in this PSOCT, the similarly it can also be documented clearly in PSOCT compared to the STOCT. So the limitation are incompatibility with the commercially available systems and cross-coupling artifact in fiber optics and difficulty in measuring a true depolarization. Thus, to conclude, OCT technology continues to address the certain limitation observed in current standard of care for choroidal and retinal diseases, and these advancements will help you in advancing the basic science research and our understanding of the pathophysiology of the chorioretinal diseases. Thank you.
Thank you, Shruti, for that enriching talk. Over to Dr. Ankur for the discussion.
It was a wonderful compendium of the talks on OCT. I think OCT is the most important discovery in ophthalmology. So I will let's go on with the speakers. So Shruti, I just wanted to ask you is that you have talked about OCT angiography, IOCT, intraoperative OCT, as well as other advancement in OCT. What do you think to the audience over here? How important is so the first machine that we buy should be an OCT or an OCT angio with an OCT angio?
First, we should buy OCT machine, but currently we want Octa also for actually ruling out the diabetic retinopathy cases. Instead of doing an FFA, we can do a OPD procedure with the less time, without any non-invasive procedure. Invasive procedure, we can order an Octa to look for the foveal avascular zone and capillary non-perfusion area. So Octa will help in making a clear diagnosis in most of the cases. Like in CNVM we can look for the network, and in non-exudative cases we will not get an idea in FA or OCT, but in non-exudative cases when we order an Octa, we can clearly appreciate the network. So and we can initiate whether we should initiate treatment or not, we can decide upon that. So Octa is also needed nowadays, but we cannot skip FFA also.
So that brings me to the second question. Has the Octa replaced FFA?
Not fully, but still we want FFA
So
also.
in your practice, which are the patients that you directly take to Octa rather than doing an FFA?
Like in DR cases, we can skip. We want to know the when wide field octa is available, so we can actually skip an FFA to look for the peripheral non-perfusion areas or ischemic areas. We can, or neovascularization. We have doubt of neovascularization. We can actually order an wide field octa instead of doing an FFA.
Thank you. So what I usually do is that whenever a diabetic patient walks into my clinic, I always get the patient, if the patient I think has a severe NPDR or has a CSME, I always order an FFA. So baseline FFA in diabetic retinopathy is still needs to be done. But then because the doctor has the benefit of being non-invasive, you know the pathology, you can follow up that patient on OCT angiography rather than repeating the octa. One patient I really don't think about FFA is when I'm looking at the macular pathology. So all those CNVMs can be treated on octa and in a very beautiful way because you can identify the size of the CNVM complex, you can visualize it, you can see it resolving. At the same time, what do you think about the intraoperative OCT? You think the intraoperative OCT is a tool that everybody should have?
No, actually, it's a ongoing study. Like Pioneer study and Discover studies are doing to look for the advantages of intraoperative OCT. It helps the surgeon to decide whether the peeling is complete or the macular hole is closing or the retinal detachment is settling. We can get an idea, but currently it's not in a common practice. No.
So, how far I understand is that intraoperative OCT, I have done a lot of work on intraoperative OCT. So, as of now, they stand only in a teaching institution. What the benefit of having an intraoperative OCT is when you are in a learning phase and you cannot identify the structures, it helps you to identify an ERM because you can literally in between the surgery look at those areas which are known as pick areas in the ERM and you can identify this is the where I have to peel. So interoperative OCT, very good tool, but then as of now, I think only a tool where it can enhance your learning rather than having all these studies have shown that it has a better outcome in surgeries, but I still feel that is still a learning tool. So that takes me to the first speaker, Dr. Minnie David. Yeah. Uh, just wanted to ask, I think you spoke about the macular hole, right?
Yeah.
Yeah. So, do you think there is any role of the newer classification that is there in macular hole, the closed classification?
That
The classification, there is a newer classification that talks about the surgical outcome. So
macular
before
hole indices.
Yeah, no. So before we began with the classification, we
Yes.
had just large macular hole more than 400
Yeah.
micron. But now we know that those 400 micron holes need to be not 400 micron or 650 micron or 800 micron, even 1000 micron. Indian subcontinent has larger holes. So the treatment has to be tailor made to the situation. So now we have a surgical based classification which is known as closed arc classification that divides the larger holes into extra large, extra large, or giant macular hole. So giant macular holes are holes which are having more than 1000 micron of size. So the understanding of these things is that these are the holes which are not going to do with whatever normal technique you do. So 85% of these holes will not close with even ILM flap or the free flap or the cabbage technique, whatever you do. So these are the cases where you need to enhance, like you need to do an retinal autograft or you need to do an amniotic membranes. So this is a newer classification that is there. Apart from that, it was a very nice presentation from you. I just wanted to ask you, where do you use your macular indices in your cases? Macular hole indices in your cases.
It's not, we are not looking into a practical thing, but we can predict the closure depends on that macular hole index and the tractional hole index. We can depend on the closure or not.
Okay, fine. Thank you.
Okay.
Um, so I had a very wonderful talk by Dr. Julian, who talked about hyperreflective foci and those biomarkers, how you detect diabetic, how do you detect that these patients are going to do well with the anti-VEGFs? So I'm just going to add to that is that you have covered almost everything, but then you need to understand that the hyperreflective foci, when are there, they are the inflammatory signs. So if these are the patients, apart from the faricimab you have talked about, will also do well with dexamethasone. So if you don't have faricimab because it's a higher costly molecule, you can go for dexamethasone. In fact, if not dexamethasone, you can even give thought of giving an intravitreal triamcinolone, which is easily available. Apart from that, you need to tell the patient that he's going to have floaters. So very nice presentation. And yeah, so I think we had a very good session, and I think we have covered everything in OCT angiography and as well as the clinical aspect. I hand over the mic to Anju to please close the session.
So, with no discussion, further discussion, we'll wind up the session. I thank Dr. Ankur for this panel discussion. Thank you all.